He has a couple twins, actually one set of twins, and I know he's been thinking about not only health care at the policy level and what we're going to talk about today, but of course what that means for his children. So with that, let's start. There are a number of topics we're going to start kind of at the macro side, if you would. Scott, talk us a little bit with the craziness that's going on right now in our country, still financially and economically. Let's talk about the impact, if you will, a little bit on health care and the economy or financial.
Well, thanks a lot. Thanks for the introduction. I think we're facing a fundamental debate, and I'm not sure that it's necessarily going to play out in the 2012 election, although it's starting to shape up that way, about the direction of a lot of the entitlement programs that create tremendous unfunded liabilities. Medicare alone is a $64 trillion unfunded liability over the life of the program, and Medicaid is the second largest unfunded liability that the government has right now. And so I think we're at the point where we're starting to have a discussion around whether these programs are sustainable and whether they can continue to be all things to all people, particularly with Medicare. And that means we're going to have to confront some sort of fundamental choices about the structure of the program. The first being, is it going to be a defined benefit or a defined contribution? Right now, Medicare is basically a defined benefit. The government guarantees everyone the same set of benefits under the program. If you look at the Paul Ryan plan and other plans that have been put forward in Congress, particularly by the Republicans, they want to move towards more of a defined contribution model where people receive a certain level of subsidy to go out and buy insurance on their own, and presumably you'd means test that subsidy. That's one of the fundamental questions I think we're going to need to confront. Another one is whether or not we try to invite back entrepreneurship into healthcare delivery. I think a lot of entrepreneurs who had invested in healthcare services have left the space in the last couple of years. There's been a lot of efforts to take down the profitability of a lot of different healthcare services ventures, impose new price controls into aspects of the market, particularly from the Obama healthcare plan. And I think you're seeing a lot of the venture capitalists who've traditionally created new ventures in healthcare leave the space. And the people who are now making investments in healthcare tend to be private equity investors who aren't necessarily creating new ideas, but they're bringing financial efficiency to some existing institutions. And if you believe that the only way we're going to really solve our long-term healthcare problem is to improve healthcare productivity, get more healthcare for every dollar that we spend, you want to see entrepreneurship in medicine. You want to see people trying to come up with better ways of delivering services. And then the final question, and there's many, but I just wanted to touch on a few of them, is whether or not we're going to cling to a notion of egalitarianism in the Medicare benefit. The reason why the Medicare benefit has been sustained as a defined benefit and sort of a one-size-fits-all insurance program, regardless of people's ability to pay extra. The reason why doctors can't balance bill, the reason why senior citizens who have money to go out and buy true co-insurance can't do that, rules prevent Medigap insurance from being true wraparound insurance, is because there's a notion among many, particularly among Democrats in Washington, that if you allow some people to buy their way up or buy their way out of the benefit, over time the basic benefit erodes. And so the idea is to get everyone into the same benefit, and you have a political constituency that will force the sustenance of that benefit. And what we've seen with Medicaid is because it's a benefit that largely serves a lower income population, people who are disenfranchised from the political process, we've seen it erode. We've seen the Medicaid benefit erode, and in many parts of the country, in many states, it's really not an adequate benefit. Where I practice, I have a very hard time getting my Medicaid beneficiaries access to care. So I think that there's a concern that Medicare could go on the same downward spiral if you allow people to buy their way up or out of it. But long term, that's probably unrealistic. We're going to have to means test aspects of Medicare. We're going to have to allow people to buy true co-insurance to wrap around the basic benefit. We're going to have to allow some physicians to balance bill if we want them to stay in the program altogether. And I would argue the only way to really preserve Medicare as a basic benefit is to allow that to happen, because if we try to force everyone into it and think that it can be all things to all people and we can pay for that, that's very unrealistic long term.
So let me start. There's a lot already in what you just said. We could just focus on that. But I assume you agree that the system's broken. Let's talk about healthcare delivery when I say system. And there are fixes that are certainly somebody needs to come up with. We're going to talk a little bit about the concerns you see with the current legislation and what's in place. But talk for a moment about your own, if you will, acknowledgement that it is broken and it does need to be fixed.
Well, I think the system's inefficient, and a lot of the way that we pay for healthcare services, pay for healthcare products, leads to excess utilization, leads to waste. It's hard to fix all that because a lot of the way that reimbursement's structured in healthcare, even in the private market, is piggybacked off of Medicare. And so I would argue the reason why healthcare is so inefficient isn't in spite of Medicare, it's because of Medicare. Because the Medicare program has created rigid pricing rules, because it has institutionalized a fee-for-service model that rewards excess utilization. So if you believe that you can't just get rid of Medicare, and I don't believe you can just get rid of Medicare, it serves a vital need. I do believe you can reform it and move it into a different model, but believing that Medicare is going to continue as a major component of healthcare spending, any reform in the delivery models needs to be led by Medicare. If you're going to reform the reimbursement system, you need to have Medicare lead that reform. If you're going to create new models to invite in entrepreneurship, you're going to need to have Medicare lead some of that reform. My concern is we haven't done that. I don't think, for the most part, the President's health care plan does that, with the exception of some payment reforms that are embedded in there, which are good ideas. A lot of the plan, I think, moves us in the wrong direction of consolidating physicians into larger groups, making a bet with hospitals, which haven't necessarily been entrepreneurial.
Careful now, I'm on the hospital board.
And chasing away a lot of the private capital, I think, could lead to true delivery reform.
Okay. Just a few numbers, and everyone here knows how serious the numbers are. It doesn't matter what you talk about, but in healthcare, you know there are some 76 million baby boomers coming into the Medicare system. Anybody want to take a wild guess on how many people are paying into that system right now? 49 million. For the first time ever, there are a lot more people going into the system than are paying for the system. Just that one fact alone, of course, puts huge pressure, the very thing you're talking about, on the Medicare system. So we know it's there's a formula that right now is a formula for disaster. We're going to go on and talk a little bit more about the actual legislation that's in place today, and try not to get into the weeds. We've got about a half hour to talk, and then we're going to come back to you for questions. So, and I will take time for questions. I know sometimes I come into this room and we get so engaged up here, it's like, whoops, wait a minute, what happened to that time? But we will come back to you for questions, so please be thinking about that. So let's start on accountable care organizations. You actually have just mentioned them a little bit. You outlined what they are. So first, let's talk about what does that mean, because part of the objective, of course, has been to take the very fragmented system we all have. We go to a doctor, we get diagnosed, doctor says you got to go to the hospital. You go to the hospital, you have a procedure there. Perhaps you have a surgery there. Now you move on, you go to rehab. All those things, and by the way, floating around in the middle of all that, of course, is the insurance company. Can you do it? Can't you do it? And it's a mess. We've all been through it. You have to deal with 3, 4, 5, 6 different institutions. So one of the fundamental objectives, I know, of the legislation was, okay, let's try to package that, put it in one box, and have a continuum of health care. Let's just call it that. It's called Accountable Care Organizations, ACOs, and they're just now coming up on the edge where they're going to get started. So I know I've teed that up for you. Talk to us a little bit about ACOs, Scott.
Well, it's debatable whether they're going to get off the ground or not. Right now it's a concept, but I wouldn't say it actually exists in the market, at least as it's envisioned in the President's plan. So the President's advisors had a vision that the best way to deliver care in the country would be models like Kaiser Healthcare or the Mayo Clinic or Geisinger, where you have an integrated delivery network, in many cases coupled to a hospital. And the view was that by integrating the delivery of medical care across different specialties, you can create more coordination, more efficiency, extinguish some of the waste, and it would also be easier to regulate the actual provision of medical care because you wouldn't have to regulate down to the level of the doctor, which is hard for a remote agency like Medicare to do. You can just regulate the institutions, and the institutions within institute management controls over utilization and over their own physicians. and hopefully lead to more efficiencies. So they made a very big bet conceptually in the legislation on what they're calling accountable care organizations, which is basically incentives to try to lead to this consolidation. I think there are a lot of problems with the way it's envisioned in the legislation and the regulations which have recently come out, not the least of which is that it's very prescriptive, and most of the private enterprises who would have led some of this reform and made the investments in their own accountable care organizations are sitting on the sidelines and have basically said as much, including the Geisinger Clinic and the Mayo Clinic, which have come out and criticized the regulations. Also, the way that it's structured, the way the reimbursement is structured, the incentive for engaging in this consolidation is very small. You can earn maybe a 5% margin, maybe a little bit more off of what you're earning today. I think there's a real anathema among the president's advisors to allowing people to earn outsized rates of return on invested capital over any sustained period of time. And so they've basically sanded down margins quite deliberately. I mean, they talk about actually directly regulating the medical loss ratios, the profitability margins of a lot of the medical insurers. And I believe if you're going to get people to engage in dramatic shifts in the marketplace and make risky investments, you're going to need to hold out the potential that they can earn outsized returns on their invested capital, and this doesn't allow for that. So what's happening? There's been a lot of business plans put forward, put in front of venture investors. I haven't seen a single one get funded. I was with the CEOs of a lot of the private companies who presumably would start accountable care organizations about 2 weeks ago. None of them are doing it. They're sitting on the sidelines, and so the people who are making the investments to start so-called accountable care organizations, or at least try to consolidate networks, are the hospitals. And I believe that the hospitals are doing this not necessarily because they want to be in the business of running accountable care organizations, but they want to consolidate local market power. They've always wanted to do that. There's been impediments to doing that, not least of which is the Federal Trade Commission. The Federal Trade Commission has raised concerns around what they're seeing, which is the consolidation of local providers around hospitals and the creation of monopoly provider networks, but they're being basically held at bay politically by the administration because the administration realizes that if the hospitals are the only game in town that are willing to make investments to form accountable care organizations, then they have to make their bet with hospitals. And in many cases, doctors are very happy to sell their practices to these hospitals because they've seen their real incomes decline, because their reimbursement's been held steady over many years, and their costs have gone up. And so you're seeing doctors very willing to sell out to the hospitals. I used to practice in Stamford, Connecticut, and in that local market, the urologists sold their practice to the hospital that I worked for. The urologists did. The neurologists did. These are presumably high-paying specialties that years ago would never have wanted to work for the hospital, but in fact they're selling the practices to the hospital. So in closing, what does this mean long term? I've seen a lot of data that shows that physician productivity goes down when doctors become salaried employees. Right now, upwards of 60% of all physicians in this country are salaried employees of hospitals or hospital networks. That rate is a straight line up. It looks like the inverse proportion to the stock market lately. It's going straight up. I think in a couple of years we'll see upwards of almost 70% of physicians be basically salaried employees, and that will change the complexion of the delivery of care in the country. I'm not sure for better or for worse. I think in some respects it might be better. I think in many respects it could be worse.